So I'm really honored today to introduce my good friend, Steve Nicholls. Steve and I have worked together a long time. Steve is a world's expert in many areas. One is in atherosclerosis, cardiometabolic disease. Steve has really pioneered our understanding of a lot of different kinds of lipid lowering and athero regression. A lot of work in the imaging part of that world. He's also very, very active over on the obesity side of things. But today he's going to talk about CETP inhibition and the future. So, Steve, off you go.
Thanks, Mike. I will just share my slides and hopefully you can see them. Um, so thank you for the kind invitation, and it's a delight as a member of the Baim faculty to be able to present. And I do appreciate the slightly different time that I'm able to give this talk. Quite often, the Baim presentations are about 3 o'clock in the morning, as local time for me, so I don't necessarily get to participate in many of them. What I want to do is talk about CETP inhibition. This has been an area of interest for the field now for a quarter of a century, and a field where there has been significant disappointment, but perhaps out of that disappointment has been major learnings that inform the design of new development programs and clinical trials that may ultimately still have the potential to bring a new therapeutic to the clinic. This slide summarizes my disclosures. Cholesterol ester transfer protein, or CETP, plays an important role in the regulation of lipid metabolism. Importantly, it facilitates the transfer of esterified cholesterol from HDL particles to VLDL and LDL particles in exchange for triglycerides. And why CETP initially gained an enormous amount of interest was there was a sense from early genetic studies suggesting that having less CETP may be cardioprotective. And this notion that if one had less CETP, one would not move that esterified cholesterol out of HDL. That would lead to higher HDL cholesterol levels. And as we knew from countless number of observational studies that having low levels of HDL cholesterol was bad, surely having a much higher level of HDL cholesterol would be good. So that really stimulated an enormous amount of interest during the late 90s and the early 2000s in development of pharmacological inhibitors of CETP, and that was off the back of animal studies, particularly in rabbits, that had shown that a range of different approaches that inhibit CETP, small molecules, antisense oligonucleotides, even vaccines, appear to be atheroprotective. And that led to the development of a number of small molecule inhibitors. Here you see the first of those agents, an agent called torcetrapib. It was the first CETP inhibitor to move forward into an advanced phase of clinical development. What we observed in early studies of torcetrapib was fairly substantial raising of HDL cholesterol by probably 70% or more. Some modest lowering of LDL cholesterol in those early studies. And on the basis of those early lipid studies, we moved forward into large clinical outcome trials. And unfortunately, the large cardiovascular outcome trial was stopped early. And it was stopped early uh, by the DSMB due to this finding of an excess rate of all-cause mortality. There was a 58% increase in mortality. We saw an increase in both cardiovascular and, importantly, non-cardiovascular death. The non-cardiovascular deaths appeared to be associated in the setting of either cancer or infection. And so fatal events across the board were greater. And when we unblinded the data at that point in time, the primary endpoint, which was a fairly standard composite MACE endpoint, we saw a 25% increase in risk again in the patients treated with torcetrapib in combination with atorvastatin compared to the atorvastatin placebo patients. So across the board, a pretty bad outcome. In parallel, there had been three serial imaging studies to try and understand the impact of torcetrapib on progression of disease in the artery wall. The first of which was a coronary IVUS study that we performed at Cleveland Clinic. And what we observed in that study was addition of torcetrapib to atorvastatin had no favourable effect on progression of coronary atheroma compared to atorvastatin alone. And two parallel serial carotid IMT studies, the first conducted in patients with familial hypercholesterolemia on the left and mixed dyslipidemia on the right, again failed to show any benefit of adding torcetrapib to atorvastatin compared with atorvastatin alone. And in fact, when these serial IMT studies were reported at the time by our good friend John Castelline, he noted that the findings of these studies were as flat as a Dutch pancake. I think it would be fair to say there's just absolutely nothing going on here. So we have three imaging studies showing that despite favorable lipid effects, particularly the substantial raising of HDL cholesterol, that torcetrapib had no favorable effect on progression of vascular disease in different vascular territories, looking at different kind of states of the disease process. And that is associated ultimately with this not only failure to reduce cardiovascular events, but actually excess cardiovascular risk and excess rate of fatal events. So that was a bit of a problem. What we subsequently learned was that torcetrapib was a dirty drug, and a number of studies demonstrated a number of adverse signals which really had nothing to do with CETP and pointed to potential off-target toxicity. The first was that we saw this increase in blood pressure. And in fact, if you went back and looked at the clinical trials of torcetrapib, there was a pretty consistent rise in blood pressure in the torcetrapib treated patients. And in fact, with sequential studies, the rise in blood pressure got greater and greater. In the earlier studies, it was probably about 2 millimeters of mercury. By the time we got to the CVOT, it was probably in the 5 to 6 millimeter of mercury range. We observed in animal studies, and particularly animals that don't express CETP, that torcetrapib raises blood pressure. So certainly would suggest that that's off target. There were electrolyte changes in the outcome trial that were consistent with activation of the renin-angiotensin-aldosterone system. Animals and cell studies showed us that torcetrapib promoted increasing synthesis of aldosterone and cortisol by the adrenal gland, less nitric oxide synthase, and greater endothelin expression in the aortic wall of animal models associated with endothelial dysfunction. And so a number of findings, which all seem to be unrelated to CETP itself, suggesting that torcetrapib was a dirty drug and that it may be that other CETP inhibitors without such toxicity may still be a viable strategy and should continue to pursue clinical development. So we could summarize at the end of the torcetrapib experience that perhaps torcetrapib was a one-off. We then went on to dalcetrapib. Dalcetrapib was a less potent CETP inhibitor, raised HDL cholesterol about 30%, no change in LDL cholesterol at all. And this was a study, again, which was stopped early. Stopped early this time by the DSMB due to complete clinical futility. You can see the event curves on the right completely overlap. So the decision was made to abort development of dalcetrapib at that point in time. It is subsequently, development has been pursued by another company, which have looked at it from a pharmacogenomic perspective. Those studies remain in progress. But it's fair to say that at least the experience to date is dalcetrapib doesn't lower cardiovascular risk and it did not lower LDL cholesterol. And that's an important take-home message when we look at subsequent findings and future directions. The third CETP inhibitor was an agent called evacetrapib. This was a more potent CETP inhibitor with the opportunity to collaborate with Mike Gibson and others on this program. Again, really substantial raising of HDL cholesterol by more than 120%. LDL cholesterol lowering, which was perhaps a bit misleading. In the early phase 2 studies, we thought it was perhaps somewhere in the 30+% lowering, but I'm going to show you in a subsequent slide, perhaps that's not quite the case. And again, disappointingly, a study where a tap on the shoulder by the chair of the DSMB says there's nothing going on here. It's probably time to stop. And so the second study stopped for complete clinical futility. And I've already alluded to this, but the sense is that perhaps we overestimated how much LDL cholesterol lowering there really was with this agent. Here you see data suggesting again that 30% lowering of LDL cholesterol using a fairly standard kind of measurements as opposed to preparative ultracentrifugation, which is probably a more sensitive approach to measuring LDL cholesterol in patients treated with CETP inhibitors. If you look lower on this table and you look at the apolipoprotein B changes, perhaps that's actually giving a more honest appraisal of what was going on here. While there was a more than 30% lowering of LDL cholesterol using conventional assays, the ApoB lowering was probably more 15%. So we think in retrospect, evacetrapib was less potent than we had suspected in terms of its lipid lowering. Its LDL cholesterol lowering was not 30%, it was probably more in the 15 to 18% range. And therefore, the likelihood was that the evacetrapib outcome trial was probably too short in duration and probably too small in size. It was probably underpowered from an LDL cholesterol lowering perspective. And keeping in mind that given that all of these agents were being developed primarily on the basis of their ability to raise HDL cholesterol, we were kind of wanting to enroll patients whose LDL cholesterols were extremely well treated. So these were patients who had LDL cholesterols in the 60 to 70 range. And if you were developing an LDL cholesterol lowering agent, like a PCSK9 inhibitor, you probably wouldn't be looking to enroll patients with LDL cholesterols of 60 at baseline. So what we're able to probably summarize in retrospect was that the outcome trial for evacetrapib was likely to be underpowered and too short. And that led to the final of the kind of the first generational CETP inhibitor programs. Anacetrapib was similarly potent CETP inhibitor. You see LDL cholesterol lowering measured by both direct and beta quantification methods. We see about a 17% lowering of LDL cholesterol when we measure it properly, substantial raising of HDL cholesterol. A study that was much larger, 30,000 as opposed to 13,000 with evacetrapib, and a study that was considerably longer. The evacetrapib outcome trial, the median follow-up was about 22 months. In this study, it was over 4 years. And you can see that while it took some time for the curves to separate, there was a statistically significant 9% reduction in major adverse cardiovascular events. So we finally got there to be able to show that a CETP inhibitor could lower cardiovascular risk, but it took an enormous amount of work to get to that point. A lot of blood, sweat, and tears, and a lot of disappointment in those earlier trials. And the disappointment here was further compounded by the fact that anacetrapib, while it reduced cardiovascular risk, did not progress to regulatory approval. And that was probably for a range of factors, one of which was the finding that it had a prolonged adipose tissue accumulation. And so it never saw the light of day in clinical practice. So this slide summarizes really what was a pretty disappointing kind of decade, but perhaps with just a very small ray of hope at the end. So torcetrapib with some off-target toxicity, dalcetrapib and evacetrapib with clinical futility, one really pretty modest in its lipid effects, the other one where we probably overestimated its lipid effects and underpowered its outcome trial. And then finally anacetrapib, which at least suggests that the door might still remain open. Subsequent analysis of the anacetrapib experience continue to be very consistent with the benefits of lipid lowering. Not only this study behaves essentially like a lipid lowering trial. The event curves take a while to separate. The longer you follow patients, the better you see. And in fact, this is the longer term follow-up from the REVEAL study, and you can see when they followed people out and a median follow-up in excess of 6 years, the hazard ratio in favor of benefit of treatment with anacetrapib compared with placebo continues to improve. So, and that's very consistent with what we've seen now with a range of LDL cholesterol lowering therapies. When we looked at the relationship between changes in lipid factors and the reduction in cardiovascular risk in the REVEAL study, not surprisingly now in retrospect, raising HDL cholesterol was irrelevant. Lowering non-HDL cholesterol and lowering LDL cholesterol was relevant, and that the degree of reduction in risk was directly proportionate to the degree in reduction in atherogenic lipid parameters. And that was very consistent with what we'd seen with genetic studies as well. So we went back to the drawing board at that time, and Brian Ferentz really led some seminal Mendelian randomization studies that really enabled for us to move forward with obicetrapib. And what Brian was able to do was to say, well, look, actually, this whole field started with early genetic observations suggesting that having less CETP was a good thing. Brian went and accessed UK Biobank and other very large cohorts, and he was able to look at polymorphisms associated with having less CETP and showed that having genetically less CETP was associated with protection, and that there appeared to be a dose response relationship to that, and that genetic polymorphisms associated with lower and lower amounts of CETP appear to associate with a lower reduction in cardiovascular risk, and that this cardiovascular protection was directly proportionate to having less LDL cholesterol or ApoB. And so here you see the genetic experience where you line up CETP polymorphisms with polymorphisms associated with pharmacological therapies that we use every day in the clinic: HMG-CoA reductase for statins, PCSK9 for their inhibitors, and NPC1L1 for ezetimibe. And you can see that the genetics not only predict that hitting those pharmacological targets would be a good thing, but the degree of benefit's directly proportional to how much you lower LDL cholesterol or ApoB. And it's just really quite exquisitely striking, the work that Brian did, that suggested that it's really, to paraphrase Bill Clinton, it's really about the LDL cholesterol, stupid. If we can just lower it enough in the right patients, then that seems to be a pretty reasonable ongoing strategy.
And Steve, that plot is not a multivariate plot. That's just plotting them as univariates in Mendelian randomization.
It is,
Yeah,
but we see it hold on in
in multivariate.
multi-lipid
Yeah,
adjusted
that's what I
interventions
thought.
as
Yeah.
well. Yeah. So that then brings us to obicetrapib. Obicetrapib, a very potent CETP inhibitor, whereas many of the previous agents had required administration of probably at least 100 milligrams of drug. Obicetrapib is an agent which can be administered in doses up to 10 milligrams, and I'm going to show you largely 10 milligram data. Um, it was, again, originally developed primarily looking at its effects on HDL cholesterol. The first major report, the TULIP study, reported by Case Hoving and John Castelline, again, predominantly focused on HDL, looked like the agent was pretty well tolerated. Raises HDL a lot, raises HDL 180%. At that 10 milligram dose, we were seeing at best 120% with 130 milligrams of evacetrapib. So gives you a sense for how potent this CETP inhibitor really is. We took this agent into a formal clinical development program, and it was all subsequently about LDL. It was conducted in patients with suboptimal control of LDL cholesterol, and it was conducted where the primary endpoint of the subsequent studies were all about how much we lowered LDL cholesterol. The first of these studies was ROSE. We saw LDL cholesterol lowering by up to the mid 40%. And importantly, we used both the Friedewald conventional assay for LDL, and we used the preparative ultracentrifugation. And what was really good here was that we saw pretty good LDL cholesterol lowering, and it seemed to be pretty consistent. So right from the start, we were using both analytical approaches, and so we were being able to get a much more accurate approach of how much LDL cholesterol lowering we're really seeing with this agent. The higher your LDL cholesterol at baseline, the greater the percentage lowering of LDL cholesterol that we saw in ROSE. And ROSE was a study that was conducted with either 5 or 10 milligrams of obicetrapib in addition to high intensity statin therapy. So that was pretty promising as a first study. In terms of safety and tolerability, we saw no adverse signals on adverse events or serious adverse events, and starting to look at blood pressure. And in this study, blood pressure was measured just purely using office measurements. We saw no adverse signal on either systolic or diastolic blood pressure, relatively small study there, but at least in the early experience. And it's similarly what we'd seen with every CETP inhibitor subsequent to torcetrapib. We've not been able to replicate an adverse blood pressure signal. The ROSE 2 study looked at the 10 milligram dose of obicetrapib either by itself or in combination with ezetimibe. You can see LDL cholesterol lowering by 43% with obicetrapib monotherapy in combination with ezetimibe, more than 60% lowering. Um, Not surprisingly, those favorable effects on LDL cholesterol enabled for many more people to achieve lower and lower LDL cholesterol targets. And for example, you can see the combination of obicetrapib and ezetimibe enables nearly 90% of people. Um,
Really
uh,
good now that our target's been driven down to
yeah,
55 to see that 87% of people would hit that.
absolutely. So that's really, really good. We've used nuclear magnetic resonance spectroscopy to look at individual LDL particle effects. That LDL cholesterol lowering is associated with a 70% lowering of the concentration, the total concentration of LDL particles. In particular, that was largely driven by a nearly 90% lowering in small dense LDL particles. Therefore, not surprisingly, the LDL that remains tends to be slightly larger in size. So we're reducing LDL cholesterol, we're reducing small dense LDL, all the things that we associate, particularly with cardiovascular risk, are going in the right direction. Over the last 18 months, we've reported two large phase three lipid lowering studies. The first of them was Brooklyn. It was presented at the AHA in 2024. It's been published in Nature Medicine in the last kind of 6 weeks. This was a study of 354 people with heterozygous familial hypercholesterolemia. They were treated for 12 months in a 2-to-1 fashion with obicetrapib at the 10 milligram dose or placebo. And what we observed in that study was a reduction in LDL cholesterol compared with placebo by up to 41% at day 365. Again, that reduction in LDL cholesterol translating to really good proportion of patients getting to various LDL cholesterol targets. 50% of people with FH being able to get their LDL cholesterol below 70 milligrams per deciliter, adding obicetrapib to background statin therapy. Um, an additional kind of encouraging piece of news was this finding of LPA lowering. Now, we've consistently seen in the CETP inhibitor programs that there does appear to be some LPA lowering. In Brooklyn, we see that it's up to 50%. We did not require people to have a high LPA at study entry. The baseline LPA in these studies is essentially within the normal range. Um, but you're seeing this LPA lowering in addition to LDL cholesterol lowering. In Brooklyn, 38% of people demonstrated at least a 50% lowering of LPA. And I'll show what a pooled analysis for that looks like a little
It's
later on.
amazing, Steve. I mean, as someone who has an elevated LP(a), I'm very excited to see that. PCSK9s drive it down sometimes. I'm one of the 25% of people whose LP(a) did not change with PCSK9 inhibition. And statins don't lower it, ezetimibe doesn't lower it, exercise, diet, nothing lowers it. So seeing a 50% reduction there is just amazing.
It is, and hold that thought because I'm going to put that in a slightly broader context in
Mhm.
a few slides. In Brooklyn, we looked at blood pressure in all these studies. In Brooklyn, we embedded 24-hour ambulatory blood pressure monitoring. So now we've got a much more robust measure of tracking of blood pressure, and again, we see no adverse effects on systolic or diastolic blood pressure with obicetrapib compared to placebo. Broadway was a much bigger study, 2,530 patients. They were high cardiovascular risk, so they either had heterozygous FH or ASCVD. They had to have an LDL cholesterol that was either 100 milligrams per deciliter or non-HDL cholesterol of 130 milligrams per deciliter or higher, or you could have a slightly lower LDL or a non-HDL cholesterol in the presence of other risk factors. Again, 12-month study, patients treated with obicetrapib or placebo. And in this study, LDL cholesterol lowering a little bit lower, but still clearly much greater than we see compared to placebo. It's not, it's not, it's not uncommon for us to see in lipid lowering programs that the degree of LDL cholesterol lowering does tend to be a little bit less in subsequent studies than what you see in earlier studies. That being said, we're seeing pretty robust reductions in LDL cholesterol as monotherapy there, again, translating to favorable effects in people getting to LDL cholesterol goals. And in parallel, we saw the results of the Tandem study. And Tandem, while it included obicetrapib as a monotherapy, was pretty much conducted to be able to understand what the fixed dose effects of obicetrapib and ezetimibe would look like. So, a study of 400 patients with heterozygous FH or ASCVD treated with placebo, ezetimibe or obicetrapib monotherapy, but importantly, that fixed dose combination of 10 and 10. This was a shorter study than Brooklyn and Broadway. And here you see, and perhaps the most important finding is that on the left, the fixed dose combination of obicetrapib and ezetimibe producing, compared with placebo, a 48.6% lowering of LDL cholesterol. So, in a world where I think we should be really trying to maximize the number of patients where we are trying to get 50% plus lowering of LDL cholesterol, this combination of obicetrapib and ezetimibe looks like it might be a pretty effective tool to get there. Now, I have kind of hinted that there would be more to the LPA story. So we have done a pooled analysis of LPA lowering. The LPA lowering probably looks more in the 40% range. Again, in the spirit of the more studies you do, you tend to probably see a more of a leveling out of the effect. Um, it, as Mike's already alluded to, this is a finding that we see with PCSK9 inhibitors. We probably see more LPA lowering with obicetrapib than the PCSK9 inhibitors. It is noteworthy that a 30% lowering of LPA with PCSK9 inhibitors does independently associate with the benefit we saw in the outcome trials for those agents. And one thought that we have is that we see this lowering importantly in a range of elevated LPA that doesn't qualify for studies of the LPA lowering agents that are currently being conducted. So if you think about it, to get into many of the trials that a number of us are leading, you have to have LPA levels of 175, 200 nanomole per liter and greater. We know that cardiovascular risk is high in the context of having an LPA probably greater than 125 and maybe even greater than 100 if you look at the European guidelines. And what that tells us are that there are many people with what would be a significantly elevated LPA who simply won't qualify for treatment with pelacarsen or lepidisiran if those agents work. They're likely to be restricted by the payers to those with extremely high LPA levels. And it may be that if an agent like obicetrapib got to the clinic, it might be a useful adjunctive therapy for people whose LPA levels are elevated, but perhaps not elevated enough to get to
Yeah,
those agents.
that's a good point, Steve. Yeah.
Yeah. Now, obviously we've been down this road before. We've been down it from an HDL perspective. I've just kind of changed the twist here a little bit to it being about atherogenic lipids. The proof is going to be in the pudding of whether obicetrapib reduces cardiovascular events. This is pooled data from Brooklyn and Broadway. We presented this at the ESC last year. And you can see that if you treat people long enough in relatively small studies and in relatively short studies, we do start to see a reduction in cardiovascular events. These were not powered to look at cardiovascular events. It is an encouraging signal. If you do a landmark analysis from 6 months of treatment, you can see that the composite, either 4-point MACE on the left or 3-point MACE on the right, looks like there are less cardiovascular events in the obicetrapib treated patients compared to placebo. But um,
Steve, it looked more powerful when you got rid of stroke, huh? Do
it,
we
it,
think there's a
it, it
difference in, or not?
look, it did, and you know that there's a school of thought, and you know I know this is something that the Oxford group in particular have thought for many years about. You know, should we not be including stroke in our composite MACE for lipid lowering trials? It is currently part of the study design for the seminal outcome trial for um, obicetrapib, although you know obviously we've gone back and forth about that. Um, there are other studies that are ongoing. If one is a fan of Dutch artists, and I'm sure there's
Well,
at least one on this call,
thank you for that shout out there, Steve. Thank
yeah,
you.
there's a bit of a theme that's emerging here in what's going on. So there are a number of ongoing studies that are looking at obicetrapib. Rubens is a study that we've just started recruiting, looking at the lipid lowering effects of obicetrapib in patients with either type 2 diabetes or metabolic syndrome. Vincent is taking a proper deep dive in the setting of people with high LPA. So, you know, putting our money where our mouth is and actually saying, okay, well, we've seen these observations on LPA where we didn't need people to have a high LPA. What happens if we look at those groups in particular? And you'll notice that there's two specific cohorts that are being recruited in Vincent. Uh, those with an LPA between 50 and 125 nanomoles per litre, and those above 1 and 25 nanomoles per litre. Rembrandt is the fourth shot on goal for a serial plaque imaging study of a CETP inhibitor, being led by Mike Gibson and Jim Januzzi, and many members of the Baim community, and using serial CT coronary angiography, looking at changes in non-calcified plaque volume. And then finally, Vermeer. And Vermeer is getting perhaps a little bit more into the science and looking at antioxidant levels. And that's important because there's now some work that's being done around whether the HDL effects may still be of some use, not necessarily because of the HDL cholesterol, but its ability to carry antioxidant cargo into different tissues. This all leads to the important outcome trial, Prevail. Prevail is a study of 9,000 patients. They have established ASCVD and either an LDL cholesterol of 100 milligrams per deciliter or between 70 and 100 milligrams per deciliter, provided they have an additional risk factor, as you can see, relatively recent MI, type 2 diabetes, high triglyceride or low HDL cholesterol levels. This is fully enrolled. Patients are treated on top of maximally tolerated lipid-lowering therapy with placebo or obicetrapib. The primary endpoint is the composite of cardiovascular death, MI, stroke, as I've alluded to, and urgent coronary vascularization. There are some other findings from the CETP inhibitor programs which are worth commenting on and certainly worth ongoing exploration. Despite the disappointment of the early programs, one shining light through all of them was this consistent finding that CETP inhibitors appeared to have a favorable effect on either glycemic control or the risk of diabetes. And we saw that in different endpoints. In with the different inhibitors, we saw either less new onset diabetes, we saw more favorable effects on HbA1c in people with diabetes at baseline. And there's a whole science, particularly around the HDL, suggesting that HDL may have favorable effects on beta cells and insulin sensitivity, and that may potentially translate to a favorable effect on diabetes risk. So there is the theoretical advantage that these agents could have a cardiovascular benefit. They might even have a diabetes benefit, not suggesting that they would be mainstream therapy for diabetes, but it may certainly contribute to the benefits in patients with diabetes where we're trying to lower their cardiovascular risk. Two additional findings that are important to note. On the left, are looking at macular degeneration. This is an area of immense research interest in the CETP space. We've seen reports, particularly from the Copenhagen group, suggesting that there may be a relationship between less CETP and an increased rate of age-related macular degeneration. We've not seen any visual adverse effect signals in any of the CETP inhibitor programs, importantly, including the REVEAL study, where we now have long term follow up out beyond 6 years. On the left, you see an important observation from our group where we looked at a post hoc analysis of the ASPRE study. ASPRE was a primary prevention study of aspirin in healthy Australians over the age of 70. So, in an age group where age related macular degeneration is going to become more of an issue, and when we looked at genetics of CTP, we saw no relationship whatsoever between CTP polymorphisms and the rate of age related macular degeneration, and that included using formal retinal imaging. So, that was an important study. There is ongoing scientific investigations to try and understand the effects of obicetrapib and CETP on the eye, and we think that's where those antioxidants may be important. And a really intriguing finding from the phase 3 programs that we published late last year were the effects of obicetrapib on circulating biomarkers of Alzheimer's disease, where obicetrapib was associated with favorable effects on a range of tau-related biomarkers, and potentially leads to a whole range of new studies of asking the question, would CETP inhibition have a favorable effect on dementia? And early studies in the obicetrapib program are now starting to focus in that space. So where
Does it
does
get
this?
across the blood-brain barrier, Steve?
Yeah, it does,
Wow.
and we think the HDL can as well. Um, so where does this all lead us to? Just kind of fast forward 3 or 4 years from now, where we have a favorable effect in Prevail, and so then we would have had Reveal and Prevail both show CTP inhibition lead to a reduction in cardiovascular risk. We'd be pretty confident if there's a benefit with Prevail that it will be related to LDL cholesterol lowering, and that this agent would definitely come to the clinic as a lipid lowering agent. And it really suggests that it would be an additional tool for the treatment of cardiovascular risk. And one starts to think and speculate, well, how are we going to use all of these therapies? It's great that we're doing all these clinical outcome trials and we come together to talk about the results of them, but how's that going to translate to what am I going to do in the clinic? I can't give all of these agents to my patients. The payers won't let me do that, and the patients won't take all of them. So, um, how do we start to then think about tailoring therapy? I really like this idea that biomarkers will lead the way. High cardiovascular risk, statin plus Fluvax, and then what comes next will be guided by what we think is driving your cardiovascular risk. If your LDL cholesterol is high, you'll probably get one of these other agents, including potentially obicetrapib. If your LPA is high, perhaps you get one of these really exciting new therapies. If your CRP is high, maybe you get an anti-inflammatory therapy, and it really does go to support this idea that we are moving from a one size fits all approach to a more personalized approach to preventing cardiometabolic disease. So, in summary, we've been at this a long time, but I think we've learned a lot. Prior CETP inhibitor programs have informed that torcetrapib was toxic, dalcetrapib didn't lower LDL cholesterol, evacetrapib wasn't studied for long enough, and anacetrapib worked by lowering atherogenic lipids. Genetic studies continue to implicate, importantly, low CETP associating with the prevention of cardiovascular risk. And that prevention seems to associate with lowering of both ApoB and LDL cholesterol. Early studies of obicetrapib demonstrate good safety and tolerability, lowering of LDL cholesterol, non-HDL cholesterol, and LPA, and the potential to lower cardiovascular events, but this ultimately will require the PREVAIL study. PREVAIL has the opportunity to determine whether obicetrapib lowers cardiovascular risk and will present a new therapy for use in the prevention clinic. I'm very hopeful it will. This is why we do clinical trials. We learn, we get off the mattress, and we get off the mat, and we dust ourselves off, and we move forward. And I think that we are very grateful for those who have conducted the studies that have gone before, both the outcome trials and the genetic studies. They allow for us to be where we are today. And hopefully, in the not too distant future, we will have a new agent in the clinic to lower cardiovascular risk. On that note, I'll thank you for your attention.
Well, Steve, thank you. That was just amazing. Back in some of the trials, it looked like some of the CETP inhibitors, in fact, I think evacetrapib that we worked on, may raise CRP. It raised blood pressure, but also gave you a little inflammation. Any signal on that with your new drug? No?
No, not so far. So that's been encouraging. And we don't know what that mechanism was with evacetrapib. Um, but but we don't see any signal whatsoever with Obi.
So, are you looking at any neurocognitive outcomes in Prevail to see, did it improve Alzheimer's progression or new onset Alzheimer's?
We're not currently doing any formal study. We haven't embedded an Ebbinghaus type sub-study like Mark and Bob did in Fourier with evolocumab. I know there is an enormous, we will obviously be looking at neurological and cognitive AEs, but I think that it would be fair to say that there's an enormous amount of interest both by New Amsterdam, but I think by the broader field now in this dementia observation, and I think you'll see more and more studies start to emerge in that space.
Well, I was really excited to hear that it gets across the blood-brain barrier. There's some newer imaging techniques now in Alzheimer's research where you use radio tracers to look at kind of all think of it as Alzheimer's activity in the brain, looking at plaque and things like that. So hopefully with not too many patients, some of those fancy imaging studies could be done to see if there's a there there. That would be absolutely fascinating.
There's been a very small study looking at CSF, like when we're talking about 13 people or something like that. We're starting to see the studies. What's kind of exciting for me here is that, I think the field of cardiometabolic disease has probably believed for a long time that dementia is a pretty important complication of cardiometabolic kind of risk factors. It probably comes as no surprise that if we treat cardiometabolic risk better, you would probably lower the risk of vascular dementia. But there seems to be more to it here in that there does seem to be a potentially direct signal and association between CTP inhibition and dementia risk. And so it may be that if there is a benefit on dementia, it may be contributed by both of those pathways.
Well, we're learning that as you age, your blood-brain barrier starts to get more and more leaky. So, you don't have to begin way early in life. Perhaps if we began at age 55 or something before all the leakiness began, we could favorably impact things. So that's very exciting. How much of the benefit, if we do see a benefit, do you think it will be attributable to LDL lowering versus that LP little a lowering? I'm sure you'll tease that out in some analyses.
Look, I mean, my guess is if it works, it's probably going to be similar to what we saw with the PCSK9 inhibitors. We'll see an independent benefit. We will be able to. I always struggle with mediation analyses, to be
Yeah.
honest, to know what to really make of them. So, but it would contribute. And as I kind of alluded to, I think nobody nobody is thinking about obicetrapib as going directly head to head with the siRNAs or muvalaplin type agents. But being very mindful of the fact that perhaps for the first number of years that those agents will ultimately be available, they're going to be out of reach of the vast majority of people who have an LPA of 140. And as you know, I mean that it's a very skewed distribution. So actually, the vast majority of people that we collectively see in our clinics with a quote high LPA don't even qualify for the clinical trials that we're doing today. So certainly not going to they're not going to qualify for treatment. So then I start to think to myself, boy, if I've got an agent that lowers LDL cholesterol, lowers LPA in addition, oh, and it's got cardiovascular benefit, oh, and it might be good for my patients with diabetes. That's and my dementia risk in the long term. Um, that sounds pretty appealing.
Yeah, I went off my PCSK9 inhibitor to try and get my LP little a above 200, and I got stuck at 198. I can't do it. I'm high, but I'm not high enough, you know. So I'm very excited to hear what you're saying. In terms of diabetes, was that new onset diabetes, number one? And number two, was that in people on statins or off statins? Because we all know statins can promote the development of
Yep.
diabetes. And did you see a difference in statin treated and non-statin treated patients?
It's in patients on statins. It's both a lowering of the rate of new onset diabetes diagnoses, and in people with diabetes already, we're seeing slightly more favorable effects on HbA1c and fasting glucose, and that's very consistent with what we saw with the other inhibitors. Coshray's just undertaking a deeper dive on all of those analyses at the moment. So we hope to be able to have a more comprehensive diabetes analysis for obicetrapib available in the not too distant future. And we don't see a difference in the obicetrapib effects between those on and off a statin. The statin rate of use in these trials has been 90+%, as you can
I see.
imagine. But yeah,
Yeah,
but in the people not on a statin, we don't see a
I
difference.
see. Well, I was driving at, does this prevent statin-induced diabetes?
Yeah,
But it
well,
looks like it
well,
reduces it in both.
yeah, that it does. That's a tantalizing question in its own right. That's um, I wonder if the other thing that we're going to see over time is this statin sparing approach of moving perhaps away from 80 of a 12 or 40 of Rasuva to lower doses in combination with other things, and that probably will have the greatest impact in reducing the statin diabetes signal. We'll just simply be using lower doses.
Correct. Now, our own Jim Januzzi, who's leading the Rembrandt trial that we're working on, he says, Steve, thank you for exciting talk. I'm looking forward to crossing the finish line with you on Rembrandt and hope it provides important insights for Prevail. Jim asks, do you envision a multi-drug therapy that puts OB together with a PCSK9 or statin plus an LP little a lowering therapy?
Yeah,
So are all these different arrows, different axes? If you had to pick one to put at the top, where would you put them all?
I think the answer to the question may depend a little bit on what we see with the Horizon study. So, as excited as we all collectively are about LPA, um, I'll feel a lot more excited when we've got data showing that pelacarsen, lepodisiran, olpasiran, muvalaplin actually reduce cardiovascular risk. I think that's a big difference from association studies such as the PCSK9 inhibitors. Um, if we see that, then the notion of creating combination oral therapeutics with obicetrapib, ezetimibe, and a oral LPA would be really intriguing. Similarly, as your question started off, can you Can you make an even stronger LDL cholesterol lowering agent? Yeah, I think we're talking about the ability in the future to have therapeutics that can lower LDL cholesterol 85, 90%, whether it's an oral therapeutic or combination siRNA agents, which are currently moving into clinical development programs. We're going to run out of excuses to not be lowering LDL cholesterol at least 50% because actually we're going to have therapies that are going to be way more effective than that. And 50% is actually going to look pretty disappointing. And we're going to look pretty dodgy if we're not able to point to our patient and say that we lowered their LDL at least 50%. It's what the guidelines have been telling us that we should have been doing for years. And I think we're really now on the cusp of having an ability to do that in everybody.
Absolutely. Mine's down to 19. My LDL's 19. I think you can't be too rich, too thin, or have too low of an LDL, That's my view of it. We have a question from an anonymous attendee saying, look, there's no benefit from some of the other CETP inhibitors. If this works, do you think it's because it's a unique type of CETP? So if I may also ask you, Steve, do you think it's because this avoided off-target toxicity and had all the benefit if it works, or do you think there's something special about the CETP inhibitor in terms of the magnitude of LDL lowering or LP lowering, et cetera?
So we know that obicetrapib is highly potent and it's a highly selective CETP inhibitor, and that's got something to do with its interaction with the end of the CETP tunnel. So there's a mechanistic reason for why we see the magnitude of lipid effects with a pretty small amount of drug that we're actually administering. I think the answer to if we see benefit, why it's going to be all of the above. It's going to be that we had a non-toxic drug that was highly effective at lowering LDL cholesterol, in addition to some other things, where we actually were much smarter and we actually designed the trials properly. As I said, nobody in their right mind, if they were developing an LDL cholesterol lowering drug, would let people in with a baseline LDL of 63. Those people, that's not how you design an outcome trial. That's how you screw up an outcome trial. Um,
Hmm.
so we make the study big enough, we make it long enough, we do it in people whose LDL cholesterols are high enough. Um, that's how we show the benefits. So we have a clean drug that's effective, but importantly, we then design a really good clinical development program. And then we've had outstanding sites. And, there's plenty of trialists on this call. I mean, clinical trials are nothing without patients and they're nothing without high quality sites. And so what we're in that phase at the moment that everybody has to just kind of hold on tight and just keep as many people on drug and in study so that we can show the benefit. I think the chances are pretty good that we will.
I think so too. One of the things I wanted to ask you to kind of circle back on is this multi-drug treatment. If you're on a statin, that actually increases your absorption of cholesterol. Well, thank goodness you're on ezetimibe, which blocks some of that absorption. So you're blocking that escape pathway. And then when you block those pathways, there are some escape pathways with PCSK9 receptors. So where does OB sit in with respect to all these escape pathways? I mean, how would it possibly act on another escape pathway? Is that possible? Tell me where you see it fitting in.
We think there's some effect on what we call TICE or transintestinal cholesterol excretion. And this has been an area of interest that John Castelline's had for some time. We're very fortunate that this development program is being led by, a scientific giant.
Yes.
When you combine Castelline and Davidson together, that's a pretty potent combination in its own right, between the science and the ability to develop therapeutics. So, and I know John's been interested in this concept that there may be other effects on cholesterol metabolism beyond simply moving it, shuttling it between individual lipoproteins. And then when you combine an agent that may have potential some intestinal effects with ezetimibe that definitely has intestinal effects, that's pretty intriguing.
Yeah, I think so. The more of these different pathways or arrows that we block, the better. Well, Steve, that was spectacular. Thank you for joining us today. Thanks for all of your great, great insights. And thanks everyone for watching this Baim Grand Rounds. Thanks, Steve.
Pleasure. Thanks for having me.